Welcome to the 2020 Public Health Law Virtual Summit. We have two presentations in this session, and each presentation will be followed by a Q&A. Use the chat feature to submit your question in Pathable. If you encounter technical difficulties during the summit, go to the navigation menu and select the Need Help button. Now I will turn it over to our first speaker.
Okay, I'm just sharing my screen here. All right. I assume everyone can see my screen. Maybe Scott could just give me a thumbs up if so. Yeah. All right. Wonderful. Delighted to be here. Hello, everyone out there. Good morning, afternoon, night, depending on where you're joining us from. Really happy to kick off this session. And Scott and I are going to be talking over the next 20 minutes about the chapter that we contributed to this broader undertaking. And our chapter specifically focused on what the federal government did do or what the federal government could have done to address shortages in essential medical supplies. And most of our focus will be on PPE, so things like masks, gowns, and so forth, but we think our comments probably generalize a little bit more broadly. We each have 2 or 3 slides. We're hoping to leave a lot of time for good questions, discussion, and we look forward to doing that when we get there. So, we each have a set of high-level takeaways, and for me, one of the really sort of essential pieces of context in this discussion is that we have known, it has been very clear for quite some time that a pandemic was coming, that a pandemic would very quickly exhaust our existing supplies of critical medical resources, and that we didn't have supply chains that were in place to expeditiously fill those gaps, that our supply chains were sort of rickety and often ran through multiple countries or relied on resources which would become scarce very quickly. The way that we make sense of the story of our sort of national and particularly our federal response to this issue is a planning failure, but also a response failure. And I'm going to, kind of organize my thoughts along those two ideas. So key planning failures. The first one is very obvious. We simply have not produced and maintained adequate stockpiles of essential resources. We have mechanisms to do that. We have the strategic national supply. Hospitals could do a better job stocking. We simply fail to do that for reasons that we'll both discuss in a few moments. We have limited capacity to track inventory. So at times, there have been places where there is great scarcity, while resources were just sort of locked up someplace else. And our ability at the federal level to understand and have a thoughtful allocation program is really limited by our ability to do basic tracking of resources. There have been a number of simulations in recent years, and one thing that those simulations, tabletop exercises, one thing that those simulations and tabletop exercises has demonstrated is persistent confusion about how to use key federal laws to respond in an emergency to shortages of critical resources. Maybe perhaps the most important one of those federal laws is the Defense Production Act. And that law in particular is one where in previous exercises, federal officials really haven't known how to invoke it and how to use it effectively. Final piece that really falls into planning is that we have done a very poor job maintaining a general ability to surge production in our country. This speaks to the question that we get perhaps most frequently in reaction to our chapter, which is, why didn't the government just nationalize some of these production and manufacturing assets in our country to make masks? Fortunately, it's not that simple. The United States actually does a lot of manufacturing. So China accounts for 20% of global manufacturing. The United States accounts for 18%. 18, so just 2% less. But we do that manufacturing very differently. So in the United States, about 10% of our workforce works in manufacturing. In most of our industrialized peers, it's much more like 25 or 30%. So much of our manufacturing capacity is in automation, which is a hard thing to retrofit quickly. Can talk more about that in a little bit if we want. In terms of our response failures, the primary response failure, and this is a lot that we could say on point 3, but on point 1, perhaps the greatest failure in terms of response is just an unwillingness of the federal government to take the problem by the reins and own it and coordinate the response to it. And it wasn't just that the federal government didn't sort of lead the effort to produce, track, and sensibly allocate something like N95 masks. It actually encouraged states, localities, large institutions to compete with each other, but then it did use some of its federal authority to reach into that competition, grab resources, and reallocate them. This created a situation where states, localities, institutions were not only competing, but they were doing it in secret because they were concerned about having their resources scooped up on a tarmac, which happened a number of times by federal authorities. This led to lots of wasted effort, resources, energy that could have been used for more productive purposes. Some of the most important federal powers, legal powers, were underutilized, and they remain underutilized. Perhaps the two most important are purchase guarantees and loans. So one thing that has been observed in previous pandemics is that there is a surge in demand. Some companies in the past have met that surge in demand. So in 2009, with the swine flu epidemic, a number of companies ramped up production in anticipation of increased need for masks. But the crisis came and went, and those manufacturing lines ended up being sources of considerable loss, and a number of companies were severely hurt financially by that. The government can solve that problem. The government can say, we are going to soften and ameliorate any of that risk by just guaranteeing that it will purchase a large amount of whatever resource is needed. That has the dual benefit of then being able to restock federal supplies, which is really important. Loans are also important because, particularly for some types of manufacturing, and I know Michael will talk more about this, they're capital intensive. So if you're making N95 masks, you need specialized machinery that can do that sort of extrusion. Those machines are expensive, and the federal government had an important role to play in financing that sort of capital acquisition. Third point is just a general, again, sort of failure to take control of the situation, and particularly to a lot of the response that the federal government made was in secret. There's a lot of surreal history that maybe not productive to go through with Jared Kushner's task force, but really a broad failure to lead was sort of the overarching context. Two final points I want to make. One is that it's impossible to read our disappointing, one might say horrific, experience with inadequate PPE without reflecting on the status of healthcare in our country, and in particular, the experience over the last 7 or 8 months speaks to how much we sacrifice on the altar of efficiency, and not sort of clinical efficiency, using resources in their best purpose to maximize health, but really sort of economic efficiency. So, what this means is, in the manufacturing base, we've bought out many of our manufacturing employees because that's more efficient. We use automation. For hospitals, it means just-in-time purchasing, which is more efficient. So, just purchasing when you get down to the bottom of your reserves, that definitely makes sense economically and in terms of profit, but it makes poor sense in terms of resilience and ability to meet sudden demand. Another sort of big high-level theme that I just want to note is there's been a lot of talk about the Defense Production Act, or the DPA. That's a law that dates back to the 1950s. It's a federal law that gives the federal government the authority to do a number of things in response to a national crisis. I think the biggest, broadest takeaway about how the Trump administration has misused the DPA is sort of conceiving of it as a tool to threaten. So, hey, GM, you better do what we want, or we're going to nationalize you. That's really not the best way to use the DPA, according to all of the research we've done. And Scott and I are not industrial engineers, but we definitely strenuously explored whether it could have made sense to nationalize some parts of our economy. The sense that we take out of the literature is probably not. That manufacturing and production is different today than during World War II, and ultimately private entities know better than the federal government about what they can and they can't do. It's a matter of setting the priorities correctly, and setting the priorities correctly really requires clarity, clarity in need, clarity in access and ways to allocate resources, and then some financial incentives. So key purchase guarantees or loans to help businesses do what they are likely to do better than sort of top-down federal control. That is, I think I'm just under my time limit there by a minute. So hope to pick this up in the question and answer after Scott.
Thank you very much. Next slide, please. Okay, so I think it's important. I'm kind of taking it a level higher, from high level to absolutely out in space kind of takeaways, very big picture, because as people who are not DPA specialists or industrial engineers, we do come at this from a perspective of public health law and effective public health practice, and indeed. I think the fact that we say that and believe that nationalization of major industries would not have been productive, and we don't think that the government can effectively be in the business of manufacturing PPE, I hope gives us some credibility when we take some of these even higher takeaway levels now. When I look at what happened with COVID-19, I think one of the many things that has happened is that the Clintonian third way, Tony Blair, neoliberal paradigm of public management, which was essentially a kind of domestication of pure Reaganite, get rid of government, has exploded right before our eyes. Next slide, please. The premises of the new public management and that have played out with incredible impact over the last 30 or 35 years all around the world are that, by and large, we should let markets and let companies within markets manage themselves. Governments don't have to do everything. Governments can be pretty light in their size and pretty light in their role. They should be, as the phrase goes in that literature, they should be steering, but not rowing. They should sort of set the direction, but let the private sector get there. This has been a mandate or a rationale for deregulation and for decreasing, if not the size of government, the resources of government. Very often we or just the capacity of government. We sort of have a natural ideological argument for letting government be bad, because then that proves that government shouldn't be doing much. And this is the theory of throwing the wrench in the spokes and then complaining that the bicycle doesn't work. But it has actually unfolded pretty clearly. I had been watching this for 20 years now as a public health lawyer, and I should have known better, but I was truly surprised at the collapse of the public health sector in this response. What we have seen now, as Evan has said, is the private sector doesn't take on the public good. Hospitals don't create their own stockpiles. Hospital systems don't create their own stockpiles. They rely on just-in-time production and procurement. So they don't have the PPE. We found that actually managing, understanding supply chains, tracking supply chains, knowing who produces what and where and in what volume and at what cost, and having that knowledge at hand when the crisis hits, actually requires a serious set of government rowers, on the seats in the galley on an ongoing basis, being in touch with manufacturers and intermediaries, the way it happens in the Defense Department. The Defense Department doesn't wake up when there's a war and say, I wonder who makes bullets. They know every day who makes how many bullets. But nobody in HHS knew every day who makes masks and how many. And part of that, I think, too, we've seen is that agencies that are led by people whose specialty is steering, but who have never rowed once in their careers, were just not prepared to respond. It just doesn't work to bring in smart consultants, consulting firms or hedge funds, and ask them to run the procurement system. Jared Kushner tried that. It didn't work. It doesn't work to have people running public health who aren't really experienced in what it takes to run a public health agency. Next slide, please. So that kind of leads us to the crazy idea for the future, which is that we need to go back to having well-resourced public health agencies who are made up, or which are made up of well-trained people who are well-treated, so they want to stay and devote their careers to public health, and who are motivated because they believe that their expertise is going to be heeded and used by leaders who come from among them. Excellence in public health, in fact, excellence in the government service, is essential if we want to have a public that supports the government service, and of course essential if we want the government service to deserve that support. Now, to get us the kind of public health personnel and agency and information infrastructure we need would definitely, cost a lot of money by conventional terms. We're not 3 times what we spend now, but possibly twice, maybe adding more, and that may seem like a lot. But think about the fact that this year we're already $2 or $3 trillion dollars into paying the cost of the lack of good government, and in fact, if we want to have an effective bridge out of the COVID crisis, we're probably going to have to spend that much again. Evan, next slide. So, we invite you to go look at the full report, which has 36 different chapters. We invite you to give us comments on any or all of those and to suggest other topics that we need to have. We intend to come out with a final version early next year to influence the post-election policy process. And now we are ready to take questions. I am looking at the chat box and I'm not seeing questions. So please start throwing, or, if you don't have a question, but you have a thought, an opinion, please offer it and we'll report it. I wish we could have you live, but this is, after all, the COVID era. So Evan, do you have anything you want to add while we're waiting to emerge?
I don't think so. I was hoping we'd have some questions, but what to add? I'm not sure. Except that this is there are multiple dimensions to this issue. I think we discovered, and it's not as simple. The hope that the Defense Production Act could be a magical bullet, I think, is not a realistic one. So we have to think. In the little learning about industrial engineering, I was struck by, I mentioned that 10% of our employees work in manufacturing. That number is 20% in Germany, which obviously treats its corporations in manufacturing base a lot differently as a matter of corporate law. So I think those chickens come home to roost.
We do have a question here now from Alexis. What would be the best way to implement the DPA? How would a successful application of the law, look?
Yeah. So I mean, from my vantage point, the first thing that you would do with the DPA is, explicitly and clearly take accountability, right? So the Trump administration should have invoked it immediately, and there are a number of mechanisms in there to create public-private partnerships, to bring people from industry in a transparent and systematic way, and then to use that expertise to design a set of financial incentives that would vary by resource to stimulate production, and then to sort of immediately think about thoughtful allocation, because that's something that we've also not had. And even in a place like New York City, there are hospitals that are sort of flushed with PPE on one side of town in the rich hospitals, and then the public hospitals on the other side of town are overwhelmed with patients and have very little PPE. So
I think that's right. I mean, I think one of the aspects of it is to understand that the PPE is a tool for a systems approach. The production of masks is a global phenomenon, and it's after the initial shock around the world when some countries like China were not exporting. A lot of places that make masks are trying to make more masks. They expect to be, making money off this. So right off the bat, you have fluctuations and complexities of international behavior. What you want what the DPA gives the government the power to do is to say, we're going to be in charge. And then to get, at least from domestic makers, information, including proprietary information about their stock, their supply chain, their pricing, and their current contracts. And if you have enough of that kind of information, and you get enough voluntarily from overseas providers, and you are getting good information from governors and state health departments about their predicted needs, you can actually make a plan. It takes some pretty experienced and skilled and prepared people. So it's hard to do now. What we're seeing with the DPA is not bad in some sense. I mean, there's been a series of deals. The U.S. has put in, used its authority to make some loans and make some contracts in various domains. It's just it hasn't been systematic. Now, I see we have a question on the Zoom chat. Just a second. As COVID-19 crisis unfolds, how well can the U.S. combat the efforts to fight this virus with the PPE we currently possess or with the development practices we have in place? I'm tempted to turn that over to Michael because I think that's going to be very much what he thinks about. I think the short answer is we are probably not ready for a fall surge. And I don't see any sign that the Trump administration, HHS, is doing anything differently than it did in the first round. Evan, did you want to add anything?
No, I think that's right. And, some of these resources also, they're not just being used in the health sector, they're being used in school settings. So there's an added level of pressure, that sort of further intensifies the need for leadership and overarching coordination.
And I know you've also talked about innovation a lot in our conversations. And I think that's another area where maybe you might want to say something about, different technologies we could be using that we don't seem to be supporting.
Yeah, I mean, I think maybe Michael could also talk a little bit to that, but, we've been burning through a lot of N95 masks. There's at least some talk of other sorts of durable masks like cappers and pappers. And, they're expensive. So it's a different sort of choice for hospitals to make, to pay $700 or $800 up front per person. But it seems like one way to have a more resilient system is if you do have some of these more expensive resources in stock. I think
so Marit asks, how useful do we think it is to look to other countries as an example of what to do or not? Marit's a German law student in America who has the sense that the German system has been more equitable in operation and structure. And I think my initial reaction is, well, the sad part about this is that this is not fundamentally about governmental styles or, forms of government or sort of bureaucratic management techniques. It's about competence versus incompetence. It's about people being there to answer the phone and people not being there. The middle management capacity of our government has been, as far as we can tell from this performance, decimated, at least in HHS and in a lot of state health departments. There just aren't people to do the work. So we didn't, we looked at this as what should we learn about the legal response? And what we generally came away with was, well, the law is not a problem. DPA gives the federal government pretty much flexible powers to do what it needs to do. The problem is the people trying to use it, and beneath them, the troops that were supposed to be ready to make a plan and implement it, who just weren't there. Okay, well, maybe we should turn this over to Michael, who brings an incredible level of expertise about this from the other end of the supply chain. Michael, you're muted.
Turn my video to. There we go. All right, so I'm here to talk about a very similar issue, related issue. I think these chapters are complementary, and really one can't be read without the other or interpreted without the other. I'm going to focus on a couple of different things. The first, looking at some reports that have been published by government agencies over the last 15 years that really laid out in very clear detail the need for PPE during crises like this. And then I'm also going to talk about an on-the-ground project that I worked with engineers, researchers, colleagues at Harvard Medical School, working on fabricating PPE in response to urgent crises at Brigham and Women's Hospital in Boston, Massachusetts. So the first, March 2020, I think we all saw this call, we need PPE. So the WHO called the chronic global shortage of PPE one of the most urgent threats to our collective ability to save lives. You saw doctors and nurses in the public domain having a lot to say. Dr. Esther Chu, who's a prominent physician on social media, was calling out and saying, you know, we need PPE, get me PPE, and really trying to bring attention to the issue by asking physicians and other healthcare workers to call out if they needed PPE. Dr. Chu and several colleagues eventually formed an organization called Get Us PPE. So this was a repository for donations and distribution of supplies in that manner. And they've done an incredible job supplying existing PPE to frontline workers across the US. Now, the story of PPE is very complicated. It seems that the federal government has largely been at odds with states and localities when it comes to accessing PPE. So there's a really compelling correspondence in the New England Journal of Medicine from a physician here in my state in Massachusetts describing his experience getting PPE. And he says, 2 semi-trailer trucks, cleverly marked as food service vehicles, met us at the warehouse. When fully loaded, the trucks would take 2 distinct routes back to Massachusetts to minimize the chances that their contents would be detained or redirected. He continues, before we could send the funds by wire transfer, 2 FBI agents arrived, showed their badges, and started questioning me. No, this shipment was not headed for resale or the black market. The agents checked my credentials, and I tried to convince them that the shipment of PPE was bound for hospitals. Now, this is a physician, chief medical officer of a hospital in Boston, trying to get PPE for his hospital. And it's just incredible they had to go through this process. Flash forward to September 2020, where we are right now. These tweets are from earlier this week. Dr. Megan Roney, who is also involved in Get Me PPE, notes that supply doesn't match demand and points to lack of government support as a primary reason for that. Dr. Esther Chu, who we saw earlier, notes that we're still short on PPE nationally, and Get Us PPE is only meeting 10% of the needs that are being reported to them. And Dr. Jonathan Reiner points out that 9 months later, why are we still reusing N95 masks? So this brings to bear a lot of the issues that Evan and Scott brought up in the first talk, but I'd like to bring our attention to several reports that were issued by federal government agencies, the National Academies of Science, Engineering, and Medicine being a prominent one, looking at PPE needs during a pandemic and really anticipating all the problems we've seen right now. So the first report was issued in 2006, Reusability of Face Masks During an Influenza Pandemic. And they noted in 2006, disposable medical masks and respirators were not designed for reuse, and there is nearly universal agreement that reuse, even by a single user, should be discouraged except in the most extreme and dire circumstances. Flash forward to 2008, a report focusing on PPE for healthcare workers. The varied regulatory certification and evaluation requirements for a healthcare PPE have largely evolved in a fragmented manner. There has not been a coordinated effort to analyze the entire life cycle of healthcare PPE or the wide spectrum of the user population. And flash forward 12 years, this remains true. Most recently in 2019, a report looking at elastomeric respirators for use in healthcare settings. The committee concludes that urgent action is needed to resolve gaps in knowledge and leadership on reusable respiratory protection in order to protect the health and safety of healthcare workers, particularly in an influenza pandemic or an epidemic of an airborne transmissible disease, insert COVID-19. So the legal authority for EUAs during COVID-19 really stems from a post-9/11 preparedness movement that we've seen across sectors in the United States. And so pursuant to authority in Section 319 of the Public Health Service Act, Secretary of Health and Human Services Alex Azar declared a public health emergency involving COVID-19. Now, the next step there, he also included a declaration that circumstances existed justifying the authorization of emergency use of medical devices, including alternative products used as medical devices. This is something I'll talk more about shortly. And under Section 564, the FDA Commissioner, Dr. Stephen Hahn, is allowed to put unapproved medical products on the market in an emergency situation to diagnose, treat, or prevent serious or life-threatening diseases or conditions caused by chemical, biological, radiological, and nuclear defense threat agents. So again, this bioterror threat. And the key here is that there cannot be adequate, approved, or available alternatives. And we know right now that that's not the case. We don't have enough PPE. So this was an editorial I wrote, co-authored in the American Journal of Public Health. It echoes Scott and Evan's points. Nationwide shortages in PPE have resulted from fragile international supply, just-in-time manufacturing, lean inventories, and limited incentives to innovate. And so we note that during the COVID-19 pandemic, local fabricators, makers, and 3D printing communities actually stepped up in a major way to produce PPE for the front lines. And we also noted that EUAs are only really needed for certain high-risk categories of PPE, such as sterilization methods, filtering face piece respirators, but not for lower risk categories like face shields or gowns. Now this brings me to work I did as part of the Greater Boston Pandemic Fabrication Team, which was under the Harvard-MIT Center for Regulatory Science, where I work. So the goal here was to prototype alternative PPE, sterilize to extend use of PPE, rigorously test these potential solutions. That means clinical testing in hospital settings, distributing that knowledge that we gained through website, preprints, and publications. And then anything we made that was 3D printed or otherwise produced was put out in the public domain as an open source, clinically vetted design. And so we've produced face masks or face shields, mask frames, PAPRs, powered air purifying respirators, and sterilization techniques over the course of the last 7 months. And so this is the chapter in the pandemic policy playbook that I authored. There are a lot more recommendations in that chapter that I think are worth looking at. I am again going to focus on some of the recommendations that were made in the past, and then look to some of the recommendations that are being made in the future. So the N95 mask, you've all probably seen one of these, perhaps have one. N95 stands for non-oil resistant and filtering 95% of particles greater than 0.3 micrometers in size. So this includes viruses like COVID-19. So N95s are regulated by NIOSH, the National Institute of Occupational Safety and Health, which is under the CDC. Two important considerations for N95 masks are fit, which captures whether the mask forms a tight seal around the face, whether external air gets around the mask or not, and filtration, whether the mask actually does what it's supposed to do. So filtering 95% or more of particles without affecting the user's ability to breathe normally and without introducing new particles into the respiratory tract. So we looked at a process for filtering and reusing N95 masks. We conducted this study at Dana-Farber Hospital, focused on sterilizing N95 masks using specialized chambers and ionized hydrogen peroxide. And we found that the filtration efficacy was preserved for up to 10 cycles of sterilization. Now, these are chambers that are available in a lot of research facilities. They're often used for animal research products. And so they're available, they exist in major medical centers, and they can be used easily. We found that our process to study this was actually more rigorous than the Battelle system for sterilization of N95 masks before Battelle received its EUA and $400 million grant. And there are concerns that this was a politically motivated maneuver or a favor to one of the legislators in the US Senate. So Battelle, even though it received this $400 million grant, charges $325 per mask to sterilize. Now, I will note that before the pandemic began, N95s cost about an average of $1. And of course, if you go online on Amazon or eBay, you're going to see that N95s are far, far higher priced than that right now. Interestingly, the manufacturer of the product we tested for up to 10 cycles has to date been unsuccessful at obtaining its own EUA, even though it submitted its application in April. This also brings us to fit. So, as we noted, filtration may be preserved for multiple cycles of sterilization, but other factors may limit the reuse, just simply elastic band breakage. So we've had cases where the elastic bands break before the physician or clinician can even use the mask for the first time, forming a poor seal around the face. You'll see in image D here, this particular mask looks way too big for this physician to be wearing it. Facial injuries from prolonged use. The physician in image D there also studied this as she is a dermatologist, looking at lotions, creams, etc. applied to the face to try to protect delicate skin around the nose, but checking and seeing if that's really going to affect performance of these masks. And as I said, differences among manufacturers, sizing, and fit. So in the ideal setting, we have a number of masks. Individuals use the mask that fits them the best, put it on, and go to work. In a resource-limited setting like COVID-19, we may not have that option. And so we developed a piece that goes over the mask. It replaces the need for elastic bands, and it also has copper wire that helps fit the mask to the face, again, to provide a good seal. We also studied quality of imported filtering face piece respirators. So early in the pandemic, an EUA was issued allowing importation of non-NIOSH approved FFRs. These are the KN95s that often came from China. And I will note that 7 months after the start of the COVID-19 pandemic, there were over 100 different makes and models of these N95 masks in the inventory of local hospitals in Boston. And these are the donations that poured into hospitals as the crisis began to unfold. In a normal setting, they have 2 to 5 models, again, because not every mask fits every person. We found that a substantial number of these unfamiliar masks were from unknown manufacturers. Many did not perform to accepted standards for filtration testing and are likely to be counterfeit. And interestingly, if you were following the news in the greater Boston area, the New England Patriots plane flew to China, procured a plane full of PPE. We suspect that a number of the KN95 masks or masks labeled as KN95 that were on that plane were counterfeit. And PAPRs, so PAPRs are P100, means that they are oil resistant or oil proof, and that they filter 100% of particles greater than 0.3 micrometers in size. And so this would conserve PPEs like N95s. It would not obstruct the face. And it's pretty easy to sterilize. So all you need to do is really sterilize that hood there. But the biggest limitations are cost. These are $700, $800 a piece. Noise, the air blowing through the device is rather loud. They do have a short battery life, which means that in the course of a 12-hour shift, a physician might have to switch the battery once or twice during the entire shift. And there is an unclear approval process for these products. But our group did produce a PAPR with the help of some aerospace engineers at MIT. So we actually developed one of these and are prototyping and testing it right now. So how do we study and regulate these products going forward? Again, there's more in my report, but I'll give you some summaries based on what was stated in the past. So in 2006, the report noted that Health and Human Services should be sponsoring or conducting research on the use of alternative materials, including bioactive fibers, for disposable N95 respirators to allow extended use, and to add higher durability elastomers for the straps. And so these are both points that we agree with. In 2008, federal agencies should use standards developed through a consensus-based, transparent process. So the idea here is that all of these agencies collectively regulate healthcare PPE, and there needs to be a way for them to get together and streamline that process. They also noted that Congress should expand the resources provided to NIOSH to further efforts in the next generation of PPE. This was another report in 2011. They noted focusing on the development of a new respirator class called a biological N95. Keep in mind that the majority of N95s were not designed with biological or bioterror agents in mind. And they also noted that there should be a test for these new products that should be developed, validated, and standardized. And this is, again, the process that we used when we produced our alternative PPE at PanFab. Other recommendations from my report: I think it's really important that the FDA revisits EUAs and removes the authorization from those products that fail to conduct follow-up studies of safety and efficacy. So getting your product out there, getting the EUA, that EUA should not be an open license to produce, manufacture, and sell a product for a year, 2, 3, as long as this COVID-19 pandemic extends, without any responsibility to show additional information as to how your products work. The CDC produced a list of called Appendix A, looking at counterfeit N95s and other filtering facepiece respirators. That list evolved over time. It was changed something like 15 times over the period of a month and a half. That doesn't provide certainty to anybody trying to figure out whether the mask they're about to purchase is counterfeit or does what it's supposed to do. We would argue that PAPRs really do potentially have a long-term role, especially as an N95 production has not ramped up. We would like to see more companies producing innovative PAPRs as we have, but NIOSH really hasn't provided any additional guidance as to how that process needs to unfold. I do think there's an important role for OSHA here. So OSHA really needs to issue standards to protect frontline workers from exposure to aerosol transmissible diseases. The person to do this, again, is the Secretary of HHS, Alex Azar, and this already exists in pending legislation before Congress. So there is legislation before Congress asking Mr. Azar to issue an OSHA ETS. States can issue their own standards. Many states have done this, but federal action would be much more expedient and would cover all 50 states. I also think that BARDA and DARPA, because they emerged in the post 9/11 world and are very well funded through the Department of Defense, should be tasked with a lot of the research into more sustainable forms of PPE. But the concern with BARDA and DARPA is a lot of it is couched under state secret, and bioterror threats. And so any innovations they develop with regard to PPE really need to be made publicly available. And so again, this is part of a larger pandemic policy playbook. My chapter is chapter 20. I believe Evan Scott's is chapter 23. And with that, happy to take questions.
While we wait for people to write some questions in, I have one for you, Michael. And it's to go into deeper in BARDA. In our chapter, we reported on the sorry story of an effort by BARDA to the tune of about $8 million to support a company that was going to build a kind of mask spitting machine. It's going to be able to produce thousands of masks or tens of thousands of masks on every day. And there were sort of two things about that story that struck me. One is it wasn't that much money, given the size of the problem, the kind of reports you're talking about. It was very, very, very limited investment. But secondly, it fell apart in one of those sort of well, we got taken over, and then this person left, and we forgot about it, and now we can't do it anymore. Sorry, sort of government procurement issues. So I mean, given you also mentioned suspicions about the Patel deal, I mean, again, the idea of the Defense Production Act as a flexible tool kind of assumes good government. Is it, as we look forward to the next few months, my feeling is I guess I'm not sure we can assume that, and I'm wondering what do we need to do? What are your, like, you were the czar, or you were writing legislation, what would you do with BARDA to try and deal with some of these issues of transparency and collusion and just blamed inefficiency?
Yeah, absolutely. I think the key with BARDA and DARPA is that not everything that they're given funding to develop is a state secret. It should be protected. There are a lot of things that need to be put into the public domain, and I think Congress really needs to spell out what specifically those domains are. I do think that if we're talking about DPA, that would be a perfect industry to say, we're going to take over the production of masks. We've fully funded this. Nothing has happened. It's time for us to use this facility and take over that production. I think that would be a perfect example. And you could pay the company reasonably for the product. So the federal government, the idea behind giving $400 million to Patel was to pay them the first $400 million of costs for sterilization. And the company went ahead and said, we're going to charge extra on top of that. And really, it's cost prohibitive to hospitals to ship all their masks, or to drive them. Even in Boston, it's driving them 10 miles down the road in a truck, getting them sterilized at $3.25 and then returned, right?
That question of cost, I think, is something also that I'm curious about in capacity. So, one of the things that can be done with the Defense Production Act is to set prices, and to make sure that companies are not going to profit too much at this time when everybody else is hurting, and to avoid price competition among states competing for the same equipment. You talked a lot about these new technologies and the way that the fabricators have risen up with their printers and tried to make things happen. What is that a feel-good story, or is that potentially something that can supply enough masks and other equipment to tide us through a continued government failure?
I don't know that we're going to have the capacity to rev that up quickly. So for example, the face shield we developed takes about 4 hours to print one. There are other forms that are a little more flimsy. It just requires cutting of plastic, but that can be done much more efficiently. So there are ways to rev production up. But I think in many cases, the PPE that we're producing is of higher quality than the commercially available stuff that was out in fair quantities prior to COVID-19. And so I think the federal, the strategic national stockpile could really benefit from contracting and acquiring supplies of these products in addition to what it's doing to try to acquire stockpiles of other commercially available PPE.
And presumably, if you got $400 million, you could ramp up quite a bit with that production. So we have a question here from Alexis, which goes back to, I think, something you alluded to, but maybe you could say more about, which is there any responsible federal agency that's supposed to be ensuring the quality of PPE? And if so, how can we improve accountability if the quality procedures that they are supposed to be implementing are not being implemented?
Right. So I think this points to the fragmentation of regulatory authority. We see this in a lot of different industries, but we really do see it in this setting. So the FDA is responsible for medical devices. OSHA is responsible for employee safety. NIOSH is responsible for testing and certifying filtering face piece respirators like N95s and PAPRs. And so that's the realm that we live in. There is no one single entity responsible for regulating all of these products. They do all fall under the umbrella of HHS in many ways. And so it would be great to see more leadership in that regard coming from Health and Human Services. Health and Human Services has the power to issue the emergency temporary standard from OSHA. The CDC and NIOSH are under HHS. The FDA is under HHS. There is a central authority that could be trying to mastermind production and dissemination of PPE. It's just not doing that.
One has to observe, it doesn't feel like rocket science. I admit again, I'm a lawyer, not a specialist in this, but we are talking about a small number of products that are ultimately made by a lot of different entities and which are available for a price and that lots of people want, and we mainly are trying to get that organized. And the fact that we haven't is awful scary.
I will say, I've found a new meaning for the term rocket science because I'm working with aerospace engineers in some of these products. They're doing incredible work.
I have a question, Michael. I mean, we still live in the land of $7 aspirins and $10 gauze pads. And that happens, to varying degrees. To what extent, if at all, can you situate some of the problems that we've had with PPE with the crazy way that we finance and pay for these supplies? I mean, if there weren't these crazy incentives to obscure the pricing of every medical good and procedure, do you think we would still be where we are, or is that part of the story?
I think the story is less about what the hospitals or the other institutions charge insurers. I think that's a tremendous problem as well. But the issue is that hospitals just don't have stockpiles, right? Hospitals don't have facilities for stockpiles. They don't have warehouses. They essentially have been dependent on the federal government to have a stockpile, that if something came up, they would have access to